So our next speaker is Dr. Stephanie Deal. She's an associate professor of pediatrics and works at several hospitals, I believe, but one of them is the Baylor College of Medicine. And I will turn it over to you, Stephanie. Thank you.
Good morning. Thanks for that introduction. My name is Stephanie Deal. I'm an associate professor of pediatrics and a newborn hospitalist at Baylor College of Medicine in Houston, Texas. I'm honored to have the opportunity to speak to you today about my personal experience with two different approaches to the birth dose of hepatitis B vaccine at two different hospitals. So next. I have nothing to disclose. Next. So hepatitis B vaccine has been recommended for all infants since 1991 and recommended in the first 24 hours of life for infants greater than 2 kilos since 2016. This is because 90% of infants who get infected with hepatitis B go on to develop chronic hepatitis B, which can lead to cirrhosis, cancer, and early death. In contrast, the hepatitis B vaccine is very effective at preventing infection and has an excellent safety profile with minimal side effects. Next. So if the hepatitis B vaccine is safe, effective, and highly recommended by professional societies, then why is it declined by families? So the literature on hesitancy regarding the birth dose of hepatitis B vaccine shows that most families who decline the vaccination are either uncomfortable with the vaccine or with vaccines in general, or have a preference to wait until later to receive it. This closely tracks with what I have found in my personal experience as well. Next. So now let me tell you a little bit more about my personal experience with the birth dose of hepatitis B vaccine. For the last 12 years, I've worked at two very different hospitals within our system. Hospital 1 is a large public safety net hospital. There are currently about 3,000 deliveries per year. And in 2024, there were 2,936 deliveries of infants greater than 2 kilos, and they're therefore eligible for that birth dose of hepatitis B vaccine within the first 24 hours. The majority of patients are on or eligible for public insurance and have a preferred language that is not English. The newborn service is primarily run by pediatric residents under the supervision of attending newborn hospitalists in my group. Hospital 2 is part of a large private tertiary care children's hospital. There are currently about 6,000 deliveries per year at this hospital, and in 2024, there were 5,961 deliveries of infants greater than 2 kilos. The payer mix for the hospital overall is pretty evenly split between public and private insurance, and the preferred language for the majority of patients who deliver here is English. The newborn service is primarily run by attending newborn hospitalists with some limited pediatric resident coverage, and also there's a subset of patients who are cared for by their own private pediatricians within the hospital. Next. The approach at each of these hospitals takes towards the birth dose of hepatitis B vaccine is very different, though. At Hospital 1, the approach to the hepatitis B vaccine is more of an opt-out model, where the order for the vaccine is included in the delegated newborn admission order set, and the vaccine is given by the nurse when the family arrives on the postpartum unit once the parents sign the vaccine consent form, which is required by the state of Texas. The vaccine is usually administered within about 12 hours of birth and often clustered with the newborn bath. If the birth parent is noted to be hepatitis B positive, though, the bath and vaccine are administered more promptly. The approach at Hospital 2 is different and more of an opt-in model. This is because the hospital's legal department has decided it is required for physicians to obtain consent for any vaccine. Therefore, the order for the hepatitis B vaccine is not included in the delegated newborn admission order set and must be entered separately by the baby's physician after the verbal consent is obtained from the family. This is done during daytime hours within 24 hours of delivery. The only exception is for infants of a hepatitis B positive birth parent, in which case the orders are replaced as soon as the pediatrician is notified by the nurse, and this is with or without a discussion with the family because it's considered treatment. The nurse gives the vaccine shortly after the order is placed, whenever that is, and the parent signs a consent form right before it's administered. Next, please. The uptake of the birth dose of hepatitis B vaccine in infants greater than 2 kilos at these hospitals is really significantly different. At Hospital 1, 99.6% of our infants over 2 kilos receive that birth dose of hepatitis B vaccine, while 88.3%, still pretty good, but lower, of those at Hospital 2 receive it. Of note, the rate of hepatitis B positive patients is pretty low at both hospitals. You can see it below, but it is higher at Hospital 1. We do have a more international population there as well. Of note, I have never seen a parent with chronic hepatitis B ever decline the vaccine or immunoglobulin for their infant at either institution. This is probably because they personally know the actual risk of hepatitis B infection. Interestingly, the statistics for who declines the vaccine are similar at both hospitals. The parents of infants who decline hepatitis B vaccine are more likely to self-identify as white and non-Hispanic, which is also the more prevalent demographic at Hospital 2. Next, please. When compared with vitamin K and erythromycin I prophylaxis, hepatitis B vaccine was the most likely prophylactic medication to be declined at both hospitals in 2024. Because the uptake of all three was really very high at Hospital 1, there's very little difference between them. The differences are more pronounced at Hospital 2, where declining routine newborn care interventions is more common overall. But the uptake of hepatitis B vaccine was much lower than erythromycin and vitamin K. Next. So I have noticed that there are 4 main reasons that families describe for declining the birth dose of hepatitis B vaccine. And the approach I take with each family depends on the reason that they're declining. The most common reason I hear is that families want to delay getting the vaccine until a visit at their primary care doctor's office. Sometimes they'll explain this because they want to make sure all the records are together, but I'm not always convinced that this is the real reason, since many aren't swayed by my explanations of the multiple, really easy way for us to get the records to their doctor's office. I believe that some of the families who are just uncomfortable with vaccines overall also state this one as their reason to decline. The second most common reason I hear from families is that it's not necessary, either because I'm negative and by Texas state law, moms have that testing at delivery, which is really nice, or that's an STD. For these families, I highlight that there are non-sexual ways of transmission and talk about the real risks of hepatitis B infection to their infants and young children using really plain language, like with words like cancer, liver failure, early death, to really highlight those risks. The last 2 reasons I see are almost never really explicitly stated by the families, but I really infer them based on the family's overall behavior. For some families, declining seems to be part of a pattern of asserting control over their birth experience. This is especially true for families that come in with this extensive birth plan and their birth didn't go to that plan. If I suspect this is the reason that they're declining, I make sure to emphasize that the family is really the ultimate decision maker here, giving them control, saying things like, this is your baby and your decision. But also, in addition, highlighting the risks of hepatitis B infection and the benefits of the vaccine and how safe and effective it is. For some families, though, declining hepatitis B vaccine seems to be a part of an overall distrust of vaccines, healthcare providers, big pharma, government, all of it. These families are the most difficult to persuade, and often they're less receptive to a discussion at all, and often are declining more than just the hepatitis B vaccine. Next, please. While techniques to address hesitancy at an individual level like that are always necessary, there are a few process-based ways that are supported by the literature as well. While not specific to the birth dose of hepatitis B vaccine, studies show that using standing orders, like we do at Hospital 1, and providing accurate information about the risk of disease are both really effective ways to improve a vaccine uptake. Although population differences undoubtedly play a role here, I suspect that having the hepatitis B vaccine as part of our standing delegated order set for newborn admissions plays a large role in our high degree of uptake at Hospital 1. Next, please. So how do I go about combating hesitancy at Hospital 2 when I'm unable to change into an opt-out model, at least so far, based on the hospital's legal policy? I have found that the words I use to approach the discussion of hepatitis B vaccine can drastically affect the answers families give me. When I first started my career, I would ask, do you want the hepatitis B vaccine for your baby? Or are you okay with hepatitis B vaccine? I quickly realized that I was getting a lot of families who declined the vaccine. So I changed to, we're going to do all the routine things needed for your baby before you go home, like the hearing test and the jaundice screen. This includes the hepatitis B vaccine, unless you have a problem with that. So I have found that this approach has led to much less declining of the hepatitis B vaccine. Using this language makes it sound like the typical routine newborn care that it is, and not extra. I found that many mildly hesitant or kind of unsure families don't want anything extra, but are really fine with the routine recommended care. The families that are firmly against vaccines, though, definitely still tell me no with this approach. So it still gives that choice if needed. Next. Now, if a family is still hesitant, despite using this more opt-out language, first I have to gauge the family's receptivity to a discussion about hepatitis B vaccine. If the family's not open to a discussion, then I've found that pushing the issue only further erodes any trust we might have had. And sometimes it makes it even more likely they'll decline other routine recommended prophylaxis and screenings. But if they are receptive to a discussion, I first ask why they don't want it, really listen and actively listen to their concerns and respond to those specific concerns. I have also found that if a family is refusing erythromycin ointment, vitamin K, and hepatitis B vaccine, they often have that level of distrust in the medical system in general, and they're harder to convince in the short time that they're in my care as a hospitalist. It really is a delicate balance to advocate for recommended newborn care while still developing that trust. And it's important to know when to accept their decision to decline and allow for that continued advocacy for the vaccination to happen at the primary care doctor's office where they can build that trust over more time. Next, please. So overall, based on both the literature and my personal experience, I have three main recommendations for optimizing the birth dose of hepatitis B vaccine uptake. First, if possible, make the hepatitis B vaccine an opt-out process by placing it with the standing delegated newborn orders, grouping the signed consent form if that's required by your state with other general consent forms, kind of putting it all together as routine care. Next, really ensure any staff, providers, learners, residents, things like that, use normalizing language when talking about the vaccine so it doesn't sound extra. And then last, with hesitant families, make sure to acknowledge their concerns and address those specific concerns to help develop some trust. When the birth dose of hepatitis B vaccine is presented as part of normal and routine care, both in our hospital policies and in the language that our healthcare providers use, I've found that it results in the best possible uptake of that birth dose of hepatitis B vaccine. And that's it. Thank you. Any questions?
Thank you so much, Dr. Deal. That was a really helpful presentation, and I love hearing all the strategies and techniques that you're using to talk to parents and sort of meet them where they're at. It sounds like the structural opt-out is obviously probably the gold standard if you can get that, but then also just you're using that sort of presumptuous message of, here's what we're doing today, is really great. So thank you for sharing your tips.